Good afternoon, everyone, distinguished guests, and the invited faculties. And now we are going to have a keynote lecture by Professor Akimasa Nakao from Nagoya, Japan. And everyone knows him. He is a honorary vice president of IASGO, and he is also original members of IASGO, as well as Professor Mohammed Abdel Wahab. And we know that he is a pioneer in pancreatic surgery, and actually he is the one who has first reported isolated pancreatectomy in the world. And he is now the president of JL Central Hospital, and also Professor Emeritus of Nagoya University Faculty of Medicine. So before I spend too much time, I would like to ask Professor Nakao to start his lecture about conversion surgery for unresectable local advanced pancreatic cancer. Let's give him a big hand.
Thank you, Chairman, Professor Takaori and Hussein, for your kind introduction for me. Today, my title is Conversion Surgery for URLA Pancreatic Cancer. This Congress, first Congress was held in 1989 in Amsterdam, and 3 years later, Professor Nicholas John Rizdakis visited to Nagoya. 33 years ago, yeah, we are so young. But he passed away. And every December, we had the postgraduate course in Athens. This is Rizdakis' house. Professor Makuchi is now ill in Tokyo, so he couldn't come. And Rizdakis passed away, and Bismuth is still healthy, and many members, when we started this Congress, we became old. And Wahab invited me, and we had a Congress in Port-Said. I talked with Professor Miyazaki. So I will start my lecture. I graduated Nagoya University in 1973, 51 years ago. At that time, senior surgeon said, "Don't touch the pancreatic cancer with portal invasion." So I made an anti-thrombogenic catheter to bypass the portal vein. So from one branch of the superior mesenteric vein to the femoral vein, or sometimes to the umbilical vein in the hepatic ground ligament. So we can occlude the portal vein for a long time, no time limitation of portal vein occlusion. So I developed. So this is the bypass between one branch of the superior mesenteric vein to the femoral vein, and this is a bypass between the one branch of the femoral vein, superior mesenteric vein to the umbilical vein in the hepatic ground ligament. No congestion of the portal system, no ischemia in the liver when we resect the portal vein or simultaneous resection of the hepatic artery. So I developed with Toray company, and this bypass was developed in 1981, 43 years ago. At that time, we could not obtain the portogram by the CT, so angiography by SMA or direct dye injection in the SMV, we obtained the portogram. Nowadays, very easy, we can obtain the program by the MDCT. But we can reject the portal vein without a time limitation of the portal vein occlusion. But ideal surgery for pancreatic cancer is isolated pancreatectomy. That means en-bloc pancreatodonectomy under non-touch isolation technique. That means arterial first is included in isolated PD. So I developed mesenteric approach in 1992. Usually, pancreatic cancer surgeons use a Cocker maneuver, but I do not first step use a Cocker maneuver. First step of the pancreatodonectomy is the mesenteric approach. So this is blood supply of the pancreatic region. So from SMA, common hepatic artery, splenic artery, inferior pancreadorsal artery, dorsal pancreatic artery, and gastroduodenal come to the pancreatic region and drainage to the portal system. So before manipulation of the pancreatic region, we ligate and cut IPDA, DPA, GDA, and drainage vein. That means isolated pancreatodonectomy. I do not use the artery first. Artery first is included in the isolated PD. So my mesenteric approach, from trich ligament to the lower border of the second portion of the duodenum, mesenterium is inside. And all connective tissues around the SMV and SMA are rejected. And IPDA is ligated and divided. So this paper I sent to the gastroenterology. So this paper was published in 1993. So first step is mesenteric incision from trich ligament to the lower border, second of duodenum. All connective tissue in the mesenterium is dissected without SMV and SMA. So you can see SMV, left side, right side, SMA. Between SMA and SMV, this area, this is the second portion of the pancreatic nerve plexus. Don't use mesopancreas. This area, there is an inferior pancreatodonal IPDA. So I do not use a mesopancreas. This is the second portion of the pancreatic nerve plexus. So in this area, you can find IPDA. This is the operative field. You can see IPDA. This is SMA, IPDA. This area is the pancreatic nerve plexus, second portion. This is a total rejection of the second portion of the pancreatic nerve plexus. It is very important to obtain the RZ rejection for the Winchester process cancer. And this is the first portion of the pancreatic nerve plexus. This is SMA, SMV here. This is the extrapancreatic nerve plexus. You can see this anatomy in the Japan Pancreas Society classification of pancreatic cancer. So, non-touch isolation PD was developed in 1993. So, I started a pancreatic cancer surgery about 43 years ago. But the beginning of the result is very bad. Gradually, this is every 5 years curve of the Kaplan-Meier line. And recently by the adjuvant chemotherapy or chemoradiotherapy, the prognosis become better and better. So I developed the isolated pancreatonectomy, but many kinds of the adjuvant therapy I used combined with radical surgery. So now, unresectable locally advanced pancreatic duct cancer, usually we do not perform the operation, but nowadays, aggressive surgery combined with adjuvant therapy, this operation have been performed. In this kind of the disease, mesenteric approach and the catheter bypass of the portal vein is essential surgical technique. So once again, no invasion to the portal vein, unilateral invasion and bilateral invasion, and complete obstruction of the portal vein with collateral veins. By the catheter bypass of the procedure, we could. So about 30, 40 years ago, my data, we could portal vein resection, but the prognosis is not so good. Type C and D are almost same. And I retired from Nagoya University 2011. At that time, I published the data. Still now, type C and D is very bad. But gradually, results became better and better. And now, I moved to the new hospital, Nagoya Central Hospital, and aggressively I resected the portal vein, type A, normal type, B, C, D, and unresected cases. So the prognosis become better and better now. So this is a resectability criteria in Japan Pancreas Society. This is almost the same as NCN guideline. So, resectable and no lymph node metastasis, black line, is very nice. And resectable but lymph node positive, and resectable, borderline resectable, and unresectable. Gradually, result became worse. But before 20 or 30 years ago, prognosis was very bad. Within 3 years, all patients died. But now we can obtain the better prognosis now. And URLA, undetected locally advanced, we aggressively started the resection. And this is a short result, short time result. Surgery first, and chemotherapy and chemoradiotherapy. But we are performing this kind of operation recently, so probably 2 or 3 years later we can obtain the exact data. So today I will show you my operative technique using 2 patients. Excuse me, please start. Started? "75 years old, you can see SMA is here, tumor is surrounded the SMA. So systemic chemotherapy, gemcitabine, nab-paclitaxel, and tumor size decreased, but still, and no SMV and no portal vein, collateral circulation. So this is collateral circulation and SMV, no SMV. So cytology negative, washing cytology, and this is the SMA line, this is the SMV line. So the first step of this operation is from mesenteric incision from trite ligament to the lower border of the second portion of the duodenum. Mesenteric is incised. So all connective tissues around the SMV and SMA are resected. This is collateral. This is SMV branches. And the ileochoric artery and vein, and the general vein, collateral circulation. SMV is completely obstructed. And this is a SMA. This is the ileochoric artery. And the middle choric artery usually ligate and divide, but the arcade will be preserved. And this is the SMA, and this is the left renal vein. And the radix of the SMA is clamped. And here is a cancer around the SMA. So we opened anterior side of the SMA, connective tissue is open. So nerve plexus around the SMA is invaded by the cancer. But along the adventitia of the SMA, we can dissect. So chemotherapy, and you can see this is adventitia of the SMA, and these are nerve plexus around SMA. So this is adventitia of the SMA, now taped. This is a second portion of the pancreatic nerve plexus. First general artery is ligated and divided. First general artery. IPDA was ligated, no distance to cut, so only ligate. And this is SMV, this is SMA. So preparation of the upper jejunum resection. And this is mesocolon. And the gastrocolic ligament is divided. You can see pancreas, you can see right gastric vein, congested stomach. We preserve right gastric vein to avoid gastric left-sided portal hypertension. So you can see right gastric vein into the femoral portal vein. We preserved gastrectomy, and this is a common bile duct, hepatic duct. GDA is ligated and divided. This is right colic vein and femoral vein. This is a right greater saphenous vein. And the greater saphenous vein is inside, and anti-thrombogenic catheter is inserted in the femoral vein to the iliac vein and fixed. Another end is inserted into the aberrant right colic vein. All mesenteric blood will flow to the femoral vein, systemic circulation. During the resection, you can see congested mesenteric blood flowed into the femoral vein. And upper jejunum is divided. Common hepatic duct is divided. And this is the pancreas with splenic vein. And the cut surface is sent to the pathologist. And this is the second portion of the pancreatic nerve plexus. And you can see this is IPDA now divided. And dorsal pancreatic artery divides. No blood to the pancreatic region. This is a common artery. This is a SMA. This is a celiac artery and the common hepatic artery. So now, SMV is clamped and the portal vein is clamped, and SMV is divided, and the portal vein is divided. All mesenteric blood flows into the femoral vein. No congestion in the small intestine. So you can see no congestion in the small intestine. Reconstruction of the portal vein. And the catheter is extracted from the femoral vein, and the measurement of the portal venous pressure, very low. That means a good anastomosis. And another side is extracted. A reconstruction of the alimentary tract was finished. No blood transfusion. Next is all the same, but long SMV resection. 62 years old female, and you can see large mass in the pancreatic region, and no portal vein and no SMV. And you can see this is SMA, and the portal vein SMV is completely obstructed. So we performed the Holfinox and the chemoradiotherapy, and the tumor slightly, the size is decreased. But SMA invasion and SMV and SMA invasion. But the SMA is no, you can see this is a portal vein, splenic vein, and SMV, very narrow. You can see this is SMA, and right, replace the right hepatic artery. This is SMV and portal vein. So SMV and SMV is a problem. You can see here the cancer embedded to the mesenterium. And the gastrocolic ligament is divided, and you can see here invasion. From toric ligament, first step is a mesenteric approach. Toric ligament to the lower border of the second portion of the duodenum, mesenterium is incised. We have to preserve the branch of the SMV and SMA. Gradually, these vessels are exposed. No Cocker's maneuver. So you can see the branch of the SMV and the SMA. This is the SMA. There is the two arteries. This is the right middle choric artery and left middle choric artery. So along the SMA, we dissected the connective tissue around the SMA and the SMV. This is SMV. And two middle choric arteries are ligated and divided as a root, but the arcade of the middle choric artery is preserved. No ischemia in the transverse column. This is the IPDA, inferior pancreatoduodenal artery here, and ligated. So we do not touch the pancreatic region divided. This is the first jejunal artery, ligated and divided. This is dorsal pancreatic artery, now ligated and divided. First jejunal vein is ligated, divided. This is the connective tissues of the mesenterium, not this is the incision of the mesenterium, and this is the peripheral side of the middle choric artery. Because cancer invasion to the mesenteric artery and the middle colon, so we resect this area. Right gastroepiploic artery and vein is divided. And gastrectomy at the pyloric region. And move to the hepatoduodenal ligament. And this is gastroduodenal artery from common hepatic artery. And this is the pancreas divided and sent to the pathologist, no cancer invasion here. And you can see this is the SMA. And this is a replaced right hepatic artery from SMA. So second portion of the pancreatic region and the first portion of the plexus dissected. This is one branch from the SMA. So these are nerve plexus. This area is the first portion. This area is the second portion. So upper genital is divided. And right superficial femoral vein is harvested to use a reconstruction of the portal vein. This is a portal vein, and this is a graft. This is a SMV, and this is a graft. Reconstruction is finished, and SMV blood flows into the femoral vein. And the clamping of the SMA is declamped. You can see pancreatic jejunostomy, choroidochojejunostomy, and gastrojejunostomy and Brown's anastomosis. And postoperative CT, you can see the good flow of the harvested femoral vein. Thank you for your attention.
Thank you very much for this very illustrative, elegant presentation. I think that we may have some questions. Yes. One question only.
We do not use heparin because this catheter is anti-thrombogenic catheter. The surface of the catheter is combined with heparin. So no coagulation on the surface of the heparin. Special expensive catheter, which was made in Japan, Toray company. No. And after operation, we perform the reconstruction of portal vein. Sometimes artery. We do not use heparin.
So these are adenocarcinoma or neuroendocrine.
This is adenocarcinoma.
All.
Yes.
Thank you very much. I have to finish this session. Anyone have a question, he can ask a professor after the lecture. Thank you very much.
Thank you.